Hi, after a really long time, we are back and we are thinking to start this entire module with a very important gland, one of the most important glands, and one of the most commonly affected glands as of today, as of this generation, is thyroid. And the incidence of finding a hypothyroidism or a thyroid dysfunction or even an autoimmune thyroid disease is so high that it makes these topics one of the most important topics that we have. So before getting into all the diseases of the thyroids, first let's just look at the anatomy of the thyroid, and let's just see the different basic parts like the anatomy, the physiology of the thyroid. Okay, so let's go with the anatomy first. And first of all, you should know the thyroid is a butterfly shaped gland, and it has two lobes, obviously, which is joined by an isthmus, and it lies below the cricoid. Right, it lies below the cricoid, and very important to know is also that blood supply of thyroid is by two arteries. One is the superior thyroid artery and the other is the inferior thyroid artery. These are the basic considerations. Why? Because we need to know while doing a total thyroidectomy, these arteries are very important areas of hemorrhage. So it's really important to ligate these arteries, and to know exactly where we ligate it as well is really important. So you have your superior thyroid artery. Obviously, your superior thyroid artery is a branch of your external carotid artery. So I'll write your external carotid artery in brackets. Your inferior thyroid artery is a branch of the thyrocervical trunk, which actually comes from the subclavian. Correct. So you've got your inferior thyroid, you've got your superior thyroid. A very important point is that this inferior thyroid artery, they supply the PTH as well, that is the parathyroid gland as well. I write parathyroid, instead of writing parathyroid gland, I've written PTH, which basically means the same. Okay, and then we also have a very important artery, another very important artery, which is called as your thyroidema artery. And if this is the isthmus, this connecting to the lobes, butterfly shaped lobes, your thyroidema artery supplies the isthmus, and it's a direct branch from the aorta. All right, so this is your thyroidema artery. It's not always present. It is present most of the times. Sometimes it's also absent. You do not see it. Then we have the venous drainage. Again, the venous drainage is super important because we do not ligate directly the artery. We go first to ligate the veins because they are more superficial and of lesser pressure, so you can definitely ligate them. So first vein that you ligate is your middle thyroid vein. So your middle thyroid vein, you've got your middle thyroid vein, you've got your superior thyroid vein, and you've obviously got your inferior thyroid vein, right? So your inferior thyroid vein drains into the brachiocephalic, which is obviously then going to drain into the SVC. But your STV and the MTV, that is your superior thyroid vein and the middle thyroid vein, drains first into the internal jugular vein. So far, so good. So let me just get back at it again. Again, the blood supply, you've got a very important superior thyroid artery, you've got your inferior thyroid artery, and you've got your thyroidema artery. Superior thyroid is from your external carotid, inferior thyroid is from thyrocervical. Thyroidema is directly from the aorta. All right. Then you've got the veins. You've got the middle thyroid vein, which is the first to be ligated, and it drains into the internal jugular. You've got your superior thyroid vein, and you've got your inferior thyroid vein. Inferior thyroid vein drains into the brachiocephalic. So I guess that is good so far. Correct. Then we've got the nerve supply, and the nerve supply is also really, really important. We know that the vagus has two nerves. One is the superior laryngeal, and we've got the recurrent laryngeal, right? So we've got two branches of the superior laryngeal. One is the external laryngeal and the other is the internal laryngeal. The internal laryngeal goes into the thyroid cartilage, the internal laryngeal. So it goes deep to the thyroid cartilage and disappears. Okay, it supplies basically the larynx, the upper part of the larynx above the cricoid. Above the cricoid, by that I mean actually above the vocal cord. Okay, so let me just write sensory supply above the vocal cord. Okay, not really important. Let's just remove internal laryngeal out of this entire diagram for simplicity purpose. Okay, so let's not get involved with the internal laryngeal right now. Let's just look at the external laryngeal. Well, the external laryngeal actually runs quite close to your superior thyroid artery, and in towards the end, that is very close to the gland, it really separates out. And that is really important, because when you have to ligate a particular artery, and in this case your superior thyroid artery, you want to ligate it far away from the external laryngeal nerve, and that is very close to the gland. So if someone asks you, where do you exactly ligate your superior thyroid artery, you ligate it close to the gland. Close to gland. What about internal laryngeal? Internal thyroid artery. What about that? Where do you ligate the internal thyroid artery? Again, a very important point is that there is a recurrent laryngeal nerve, the right and left, and both of them loop. They loop, and that is why they are called as recurrent. Now, when they loop and they come back up and they have to supply again the thyroid, they go and supply the thyroid. Or they don't really supply the thyroid; they supply the muscles of the larynx, and the external laryngeal nerve actually supplies the cricothyroid muscle. Okay, they supply the cricothyroid muscle. So these are some muscles that they are supplying, and cricothyroid is the muscle that is actually an adductor, and it also actually tenses the vocal cords. So cricothyroid is a muscle that is used to increase the pitch of the sound. All right. So right now, while I'm speaking, obviously when I have to speak in a louder tone, I am using the cricothyroid. Then we have your external laryngeal nerve and the recurrent laryngeal nerve that runs it really runs close to the inferior thyroid artery, and it lies at the inferior pole. But again, the inferior thyroid artery, as it goes close to the gland, it splits into its various branches. So again, you need to ligate your inferior thyroid artery again very close to the gland. So again, the ligation of the inferior thyroid artery is close to the gland, again for the same purposes of not damaging any of the nerves. All right. A very important structure that you should keep in mind, a surgical landmark when you're talking about your recurrent laryngeal nerve. Okay, when you're talking about your recurrent laryngeal nerve, the course of the recurrent laryngeal nerve is such that it actually loops down on the right and on the left. On the right, it actually hooks around a very important artery. It's called the subclavian artery. It hooks around the subclavian artery. All right, this is your subclavian artery. So as you can see, it's literally hooking around the subclavian artery, and on the left, it's actually hooking around obviously the aorta and the subclavian artery. So as these nerves hook around and they go up, okay, they lie very close to the gland. All right, they lie very close to the gland, and they lie very close to a very important point called as very important structure. Okay, the structure is called tubercle of Zucker-Candle, and you've also got the Berry's ligament. So these are the two structures that are in close proximity of the RLN. So sometimes this can come as a surgical question. All right, so far so good. I guess we've covered most of the basic anatomy that is associated with the glands, and obviously you've got a fascia that's around the entire thyroid gland, and the condensation of the pretracheal fascia to the thyroid is something called as your Berry's ligament. It's called the Berry's ligament. All right, and this Berry's ligament is something that's in close proximity again with the RLN, as I've said. Okay, so far so good. And now let's look at the basic physiology of the thyroid. Well, the thyroid actually acts via the TSH receptors. Now, the TSH is secreted by the pituitary. The pituitary secretes TSH, that is the thyroid stimulating hormone, and it goes and it acts on the TSH receptors that are present on the thyroid gland. Okay, so if let's say this is your thyroid gland. Okay, so you've got your TSHR, it goes and it stimulates the TSHR. What TSHR does is that it increases the iodine uptake, so it increases your sodium iodine uptake via the symporter. Okay, and your iodine eventually reaches inside the gland. So now let's zoom into the gland and to see what happens inside the gland. Once the iodine is inside, you've got, obviously this is, let's say, one of the follicles, the thyroid follicles. We've zoomed into the thyroid, and this is one of the thyroid follicles. Okay, so if we zoom into the thyroid follicle and we see that here there is a sodium iodine sodium iodine sympater, and your sodium and iodine is inside. Now obviously here is your thyroid follicle, and these are the thyroid follicular cells. You've got your iodine that comes in as your negative I minus, just as an ion. Okay, it's not in your molecular form, it's in the, as we know, iodine is, this I2 is actually a molecular form of iodine. So this is actually your iodide anion. Like we have the chloride, we have the fluoride, we also have the I1 minus, which is actually iodine or iodide ion. Now this iodide actually goes with the help of a molecule called as pendrin, and it eventually reaches your follicle. Inside the follicle, we've got a very important enzyme called as the TPO. It's not inside the follicle, it's actually on the luminal side of the thyroid follicular cells. And what this TPO does is the thyroid peroxidase enzyme. It causes organification, so your I minus, okay, adds together to form your molecule I2. Once you've got your iodine molecule, what this also does is that there is a lot of tyrosine residues. All right, there are a lot of tyrosine residues that are present inside the follicle. That is, you've got tyrosine residues in a chain, correct? So this causes organification of those tyrosine residues, and causes organification, that means it adds iodine to these tyrosine residues. So let's say if this is a tyrosine residue, okay, it adds iodine at one of these hinges. And then what this TPO molecule also does is that it breaks these tyrosine residues to form T3 and T4. So let's say if it breaks this 3, it forms a T3. But let's say if it breaks in a chain 4 iodines, okay, so it forms T4. It's precisely T4. And this is exactly how your T3 triiodothyronine and tetrathyroxine is formed. Okay, and once this is formed in the follicle, it undergoes endocytosis, and eventually iodine, the entire follicle with the T3 T4 releases itself, exocytosis occurs, and it releases itself into the bloodstream. T3 T4 bind to a very important protein called as thyroglobulin. Okay, and this thyroglobulin acts as a very important tumor marker. Very important. So this is the basic physiology as well that's been covered very quickly. Fair enough. So let's say you are in an OPD and you have a patient that's coming and he says that there is a generalized swelling on the neck. All right, there is a generalized swelling in the neck. How do you want to do an examination? Obviously, you stand, you check for visible examination, you do a gland mobility testing. You check for the lower limit of the swelling. You check if there is a retrosternal involvement. Basically, if this is the sternum and if the gland goes here, behind the sternum, it's called a retrosternal thyroid. So if there is a retrosternal thyroid, you want to check for that. Also, you want to check if the lower limit is felt or not. If the lower limit is felt, obviously your thyroid is way above the sternum and it's not a retrosternal. But let's say if there is a swelling and the lower limit is not felt, might be there is a retrosternal involvement. So how do you want to actually examine the entire patient? There are 3 methods. This is called a Pizzillo method. You've got Lohé's method, and we've got Kreil's method. It's not really important to know the names as such, but obviously if someone asks you what is the Pizzillo's method is basically you stand behind the head of the patient and you basically ask him, you ask the patient, actually stand in front of the patient and you ask the patient to fold his hand and extend his head. While he extends his head, the entire bulge becomes more prominent, the enlargement of gland becomes more prominent. Then you check for the uniform nature of the gland, if there are any nodules of the gland as such. Okay, if there's an isolated nodule, if there's a toxic nodule, okay, if there's a plumber's disease, you know what's a plumber disease, right? It's a toxic nodule of the goiter. So you want to rule all of those out, and you want to do a very classical clinical examination of Pizzillo. Then you also have to check for a Leahy's method, and Leahy's method is basically, let's say if this is your thyroid, if this is your trachea, and obviously here somewhere is your thyroid swelling, you push your thyroid from one side and you feel on the other side with the palm. You feel it with the lateral borders and you check for any nodularities again. Okay, very important is that you do not do it together on both sides. Obviously it can lead to a syncope. Okay, and then we also have something called as a Kryle's method, and a Kryle's method is again using the thumb. You use the thumb of the or you use the thumb and you examine the patient's swelling to check for any nodularity. That's about it. Then you've got certain eye signs that you should obviously know. One of them is obvious, very obvious. We've been studying this since probably school time. Is that we have something called as the, obviously we've got the bulging of the eye, right? So you check for the bulging of the eye or exophthalmos, very important. Also, you check for von Graves sign. You check for Stellwag sign. Stellwag sign is basically less blinking. Stellwag. For some reason, a lot of importance is given to the namings of these signs in Indian examination. So you've got a Pizillo, you've got your Lohis. Lohis, you want to remember that you are using to push the gland. Krilis, you don't want to think about the thumb. Pizillos, you want to think about a man who's just extending his neck. Stellwag sign is basically less blinking, you're not blinking enough. Very important is your Joffrey's sign. A Joffrey's sign is basically you're not having wrinkles on your forehead. Okay. And then you have your Mobius sign, and Mobius sign is when you cannot converge, your eyes fail to converge. So those are the few signs, very important few eye signs. Okay, so now if you've seen certain things and you know that, okay, there is definitely a thyroid involvement and you can really make it out, you want to go for a very specific testing. So you do a thyroid function test, you check for T3 T4 levels, you check for TSH levels. Obviously if your T3 T4 is low, your TSH levels are going to be high, and vice versa. Then what you do is that you check for what is the most sensitive. Obviously the most sensitive is TSH. There's no point looking at T3 T4 unless you've looked at TSH. Sometimes people make that mistake, and that's just a very amateur mistake, I feel. And then you do an ultrasound. You do for an ultrasound and you check for any nodularities, you check for any gland enlargement, and on USG you can know if it's a benign, malignant. You get an idea. You do not really know unless you do a fine needle aspiration cytology. But obviously when you do a USG, you can figure out if it's a malignant or a benign condition. You check for taller, wider cells if it's a malignant. If it's hypoechoic, so when it's hypoechoic, as a rule it's kind of always malignant. Hypo. You check for any increased vascularity, you check for any lymph node involvement as such. Okay, and then you have your USGs. Okay, so then you do something called as a Thyroid scoring. A Thyroid scoring will tell you if you should do an FNEC or not on the basis of the finding of a USG. Okay, and if your Thyroid score is 1, 2, 3, 4, 5, if it's 4, 5, if it's 3, 4, 5, you should definitely go for an FNEC. Okay, so that once if your thyroid scoring is coming as 3, 4, 5, you go for an FNEC and you check by doing a fine needle aspiration cytology. And the requirement is that you should have 6 group of cells, and you should have at least 10 cells of each. Okay, at least 10 cells of each. And when you do an FNAC, you should check for you should do a Thai scoring. Okay, it's called the Bethesda classification of Thai, and Thai 1, Thai 1C, Thai 2, Thai 3, Thai 4, and Thai 5. Well, basically what happens is that Thai 3 is follicular. I start directly with Thai 3. Thai 4, 5 is where you suspicion malignancy or it's malignant. Okay. Thai 1 and 1C is basically non-diagnostic. It's not actually very clear. So you have to do a repeat FNAC. Okay. If it's a follicular, let's say if it's a type 2 Thai, so it's non-neoplastic. So you just need to do a follow-up. If it's a follicular involvement, a follicular adenoma, or even a follicular, if it's obviously malignant, it's going to fall into Thai 4, Thai 5. You do an adenectomy, basically a thyroidectomy, if it's a follicular. And obviously, if it's a suspicion of malignancy, you again have to do a total thyroidectomy. Finish it off. Once you've done your FNAC, you should do, let's say if you've done your FNAC and you know that, okay, you know that there's something not associated with FNAC. Actually, there is a case of increased thyroid production. There is a hypothyroidism. So you need to do something called as a thyroid scan. And a thyroid scan can be of two. It could be technetium or it could be iodine. Iodine is obviously used. You check for any types of Nodules. So you do a thyroid scan, you have a cold nodule, you have a hot nodule, you have a Graves disease, you can have a thyroiditis. So in a cold nodule, you will have a non-functioning nodule. Okay, it's a non-functioning nodule. There is decreased uptake, there is a decreased uptake. Okay, so there is a 20% risk of malignancy, 20% malignancy. A hot nodule, that is increased uptake, and I think it's a toxic nodular, solitary toxic nodule, and there is a 4% risk. So hot is always better. Graves, there's going to be a diffuse uptake, there's going to be diffuse increased uptake. A thyroiditis, there's going to be a diffuse reduced uptake. Okay, there's going to be a reduced uptake, obviously, because there's going to be follicular destruction in a thyroiditis. Okay, obviously it can be irreversible or reversible. Irreversible as in Hashimoto's, or if it's reversible, we are talking about something like a de Quernian or a viral thyrotoxicosis. So far so good, so far so good. Now then we can obviously do a very important, once let's say we figured out that okay, this is something like a nodule, or let's say if this is a clear case of malignancy, you obviously want to do a contrast enhanced CT, okay, CECT, and you want to see the entire involvement, if there is any retrosternal involvement or not. Okay. So let's talk about certain congenital conditions of the thyroid. Okay, so the thyroid actually starts at the foramen cecum. All right, this is your foramen cecum, and it starts from the foramen cecum. A thyroglossal tract is formed. The thyroglossal tract actually loops around your hyoid bone. Here is your hyoid bone. Okay, it loops around your hyoid bone and goes and splits into two. Okay, it splits into two. The upper part actually regresses, and voila, you've got your thyroid. And anything at any point of stage, if there's developmental issue, you can have three things. You can have obviously your lingual thyroid. So here you should do a clear cut thyroid scan. You do a thyroid scan, you see for any residual thyroid. Okay, sometimes you do not even need to remove a lingual thyroid. Okay, or there could be a thyroglossal cyst, and the cyst can lead to a thyroglossal cyst can lead to a fistula. Okay, so obviously what is going to occur in the thyroglossal cyst is that you will have a cyst that is present in the entire tract of the thyroid gland. Okay, the entire embryological tract. So you'll have a cyst that is at the area of the hyoid bone or above. Okay, and the most common site is actually your subhyoid. So you could have a subhyoid cyst, and that could lead to deglutition issue. It could lead to swelling. Okay, a swelling which moves with deglutition, or protrusion of tongue. So that's a very important clinical finding. So let's say a patient comes to you, 5-year-old kid, he says that there's swelling, there's movement of the swelling with deglutition and protrusion of tongue. Obviously, first things first, you want to do an FNAC. First of all, you want to do a USG. You want to see if there is any mass out there. Then you go for an FNAC. All right, and then you do a very important procedure called as a cyst-tunk procedure. Very, very important. Your cyst-tunk procedure is so important because you remove the entire thyroid tract. Okay, you remove the cyst, you remove the tract, and you also remove a very central, the important central part of the hyoid bone. You remove the central hyoid. So very important. And if the cyst, actually complication of the cyst is, it can form a fistula. Okay, it can form a fistula, and a very important DD that you should keep in mind is your brachial fistula. Now that's because of the incomplete fusion of the ARC2 and ARC2. Okay, the bronchial eminences. So that's brachial fistula, but obviously again you want to manage it by cyst-tunk procedure. All right, okay, so far so good. Then talking about goiters, we spoke about the congenital conditions, we saw the different methods of investigation. So now just directly look into goiters. Okay, let's jump into goiters. Very importantly, the most common cause of goiter can be iodine. Okay, iodine deficiency. So That's your diffuse goiter. So first of all, there are two types of goiters. There's a diffuse, there's a multinodule. Now, if there are multinodular goiter, obviously you want to think in terms of where why would a multinodular goiter actually occur when there is a lot of TSH? Okay, and why is there more TSH? Because there's low T3/4. So when TSH increases, obviously certain areas of the gland undergo hyperplasia and they form goiters. All right, nodular goiters. Okay, and after that, it's very important to note is that you can the most common cause of diffuse is obviously iodine. Okay, and your diffuse usually goes into your multinodular goiter. Sorry for the notification. uh, then you have to think about your isolated nodules. You have to think about dominant thyroid nodules. Okay, and then you have to think about nodules that can progress into cancer. As I've said, there's only a 4% chance of a hot nodule progressing to a malignancy, and 20% chance of a cold nodule progressing to a malignancy. Okay. So there are two types of nodules. You've got an isolated nodule. So let's say the entire gland is not palpable, but the nodule is really palpable. This is an isolated nodule. And a dominant thyroid nodule is when the entire gland is palpable, but also your nodule is palpable. So basically, these are just two important, not really important, but just these are two different classification based on the palpation. Okay. But why is it important is because if your isolated nodule, if it's a solid variant, okay, if it's a solid variant or if it's a cystic variant, okay, if it's a solid variant, there's a very high chance of, there's a 24% risk of malignancy. Okay, and very, very important is that if it's a cystic chance, there's a 12% chance of malignancy. Whereas in a dominant nodule, if it's a dominant nodule, that means the entire thyroid gland itself is enlarged, it's palpable, and then on top of that, another toxic nodule is also palpable. Then your chances of a solid nodule being is 12% malignancy. And if it's a cystic dominant nodule, it's only 6% malignancy. So cystic, cyst, sounds very similar, kind of an alliteration. So yes, that's the only important thing. I had spoken about the retrosternal to check for the lower part of the glands. Very important. Let's talk about the retrosternal goiter. Retrosternal can be primary or secondary. Secondary is when it's actually an enlargement of a diffuse goiter, and the diffuse goiter goes directly and drops into the mediastinum. So it's called as actually something called as a plunging goiter because it plunges into the mediastinum. So it's a plunging goiter. The blood supply is by the thyroid vessel or the neck vessels. Simple as that. Very easy. Prevalence is 90% cases. A primary is something which is an ectopic thyroid. And you want to do a thyroid scan, which is going to tell you if it's an ectopic thyroid or not. And the blood supply is going to be simple because it's an ectopic vessel, it's going to be mediastinal. Because it's in the mediastinum, it's going to be the mediastinal vessels that are going to supply it. What are the conditions that are going to be seen with the retrosternal? As I told you, it's going to be dyspnea, it's going to be stridor, it's going to be dysphagia also. Probably it's going to be swelling. You will obviously not be able to palpate the lower line, and very important is that Pemberton sign. Now, Pemberton sign is something which I really find fascinating. A Pemberton sign actually occurs in a lot of conditions, can occur in a lot of conditions, but it's not given the name as Pemberton. Pemberton is basically when you raise your hands. Okay, the thoracic inlet, obviously because of the abduction of the forearm and of the deltoid, there is the thoracic inlet actually narrows down and there's increased pressure in the thoracic inlet. So because of which there's congestion of the face. Okay, so there's congestion of the face, and that's very important. That's called the Pemberton sign. Okay. Once that's actually done, we have to do an investigation. If you want to do an X-ray, you can check in an X-ray. You will check for a tracheal deviation, and your tracheal deviation is not something that is actually diagnostic of your retrosternal goiter. So that's why you need to do a CECT, and that's a direct answer. If you want to do your treatment procedures, obviously your surgery, do a neck incision, mostly because it's a secondary goiter. Okay, neck incision. If it's secondary goiter, you can just pull it out. Or you'll have to do your sternotomy. You'll have to remove the central part of the sternum, and that's actually done in your mediastinal primary goiter or the mediastinal goiter. Why? Because it might be large. Second, it might show recurrence if it's done by the neck surgery. Okay, and it might be malignant. So that's the reason why you want to do a sternotomy. Well, that's the basic idea of retrosternal goiter. Once we've spoken about that, okay, let's directly look into something called as hyper and hyperthyroidism. Okay, so hyperthyroidism, hyper T3 T4. Okay, your patient is thin, irritable, weight loss. Okay, tachycardic. Okay, oligomenorrhea, tremors. Okay, all of those. So very important to know is that the most common cause of an hyperthyroidism is something called as Graves' disease or primary thyrotoxicosis. Second is the solitary toxic nodule. Okay, solitary toxic nodule. The protein involved is your G protein involved. Okay, or your factitious hypothyroidism, very rare. Actually, not as rare. If factitious hypothyroidism is basically you're taking more of T3, T4, or it could be also because of a very classical condition called as sick. Struma overi. Why am I saying sick sinus? Sorry, struma overi. Struma overi is something that really fascinates me. It's just ectopic thyroid tissue in the ovaries, and or a TSH secreting pituitary adenoma. Very rare, very rare, very rare. Usually, a pituitary adenoma will lead to hypothyroidism, guaranteed, because of the stock effect and stuff like that. Okay, so. So it's an hypothyroidism. So what do you want to do? You want to do a thyroid scan. Simple. You want to check for any uptake of iodine because it's increased iodine uptake. Hypothyroidism. Okay, so you will have thyroid scan. Most of the cases will show increased iodine uptake, except in if let's say you have a struma overi, because obviously now your ectopic tissue is in the ovary, or let's say if it's a factitious hypothyroidism. And what is a factitious hypothyroidism? It's basically you're taking increased T3, T4 exogenously. Easy, very easy. So how do you want to manage it? How do you want to manage hypothyroidism? There are three things that you should consider: your pre-op, op, post-op. We mostly combine. Most of the cases we do drugs and surgery both. Sometimes we do just drugs. Okay, that's fine as well. But always remember that in pre-op you're going to give beta blockers. You're going to give propyl thyroid uracil, okay, PTU, or you're going to give carbimazole. And what you're going to do is that it's going to decrease the entire production of T3, T4, and it's going to cause a decreased chances of a thyroid storm. Then you do your operative surgery, a thyroidectomy, a complete thyroidectomy, partial thyroidectomy, hemithyroidectomy, whatever. And in post-op, again, you continue your beta blockers. For how many days? For 8 days. Actually, you can also say 7 days, 7 to 8 days. And you do an OD dosing of beta blockers. You mostly give a nadolol. And you do your PTU, for 6 to 8 weeks before procedure till evening of that day of procedure. Okay, so you consider giving these drugs. Fair enough. A very important drug that you should give is Lugol's iodine. Lugol's iodine is a drug that not only decreases production, it decreases production of T3, T4 by a very important mechanism called the Wolff-Chaikoff effect. It also decreases exogenous release of T3, T4, and also decreases the vascularity of the gland. So it makes the entire surgical procedure much easier. Okay. So let's talk about what you should do if there is a thyroid storm. Let's say the pre-op evaluation fails, or let's say if there is any manhandling of the thyroid gland during surgery. So there is going to be a thyroid storm. So what do you do? First, propranolol. Give steroids. Put the patient on steroids ASAP. And you can also give a little bit of uh, obviously you want to rehydrate, IV rehydration, and very important is you want to give antibiotics to the patient. I was going to write something like a ketoconazole, but I do not know why, but ketoconazole is actually the one that decreases steroid formation. So writing this is completely incorrect. So the first disease that's associated with hypothyroidism is Graves' disease. Graves' disease is antibodies that stimulate the TSHR, and because they stimulate the TSHR, certain H&E findings certain very important things that I need to talk about, associated with pernicious anemia, and also with with myasthenia gravis and Addison disease. There is something that's associated with Dupuytren contracture. We'll talk about that later. Mostly it's in hypothyroidism, and it's thyroiditis that's associated with Dupuytren contracture. As I said, I'll talk about it in this very lecture as well. So H&E shows a tall and scalloping. Scalloping is very important. Okay, certain signs that you should keep in mind is your von Graef sign. As I said, your leg lag. Your decreased blinking is Stellwag. Okay, you should also keep Dalrymple sign. Dalrymple sign is basically your lid is retracted. Again, all of these lid signs, decreased blinking, Dalrymple, Stellwag, von Graef, it's all because of increased stimulation of the Muller's muscle. The Muller's muscle is a very sympathetic part of your autonomic component of your levatopalpebral superioris muscle. That's within the upper eyelid. And you've got a Morbius sign, which is decreased convergence, and your Joffrey signs, that's decreased forehead wrinkling. Obviously, very important is your pretrabeal myxedema, PTM. You'll also get a lot of glubbing, subperiosteal bone formation, dermopathy, a lot of dermopathy seen. So how do you want to manage it? Okay, as I told you, the best management is medication and surgery. So let's say if there is a symptom, asymptomatic, goiter, pregnant, and elderly with complications. So if it's symptomatic, obviously you want to go for surgery, drugs with surgery. Drugs, asymptomatic, you do not do anything, you just do your drugs. Okay. If it's a symptomatic but no goiter, you want to do your surgery. You don't want to do your surgery, you want to do your drugs plus radioiodine ablation. Very important. Very, very important. Without goiter. If there's a goiter, you want to definitely go for a surgery. Very high chance. There could be a high chance of progressing to a carcinoma. So obviously you want to keep that in mind. Again, if it's a pregnant lady, you do not want to do a radioiodine ablation. So you just want to go for medication plus surgery if, let's say, there's a goiter. And if it's an elderly patient, obviously you definitely don't want to go for a surgery. So you do a medication plus radioiodine ablation. Okay. An important point to note is that radioiodine ablation actually causes an increase in eyelid signs initially. Later, obviously, it's going to decrease. So if it's a case that, this is a patient has come and he's done a radioiodine ablation and now the eyelid size increases, is this normal, or do you want to give him, or do you want to shift to surgery? Do you think there's a recurrence, or do you think there is any leftover part? No, there's no leftover part. Radioiodine ablation usually causes increase in lid signs. That's simple as that. Okay. So in surgery, obviously you have your total and a subtotal thyroidectomy. Okay. And obviously your subtotal thyroidectomy is associated with a lot of chances of recurrence, and your return to the euthyroid state is comparatively variable. Okay. Then we have two other nodules to talk about. We have a Plummer's disease, which is your toxic thyroid nodule, toxic nodular goiter, if you want to call it. Again, you have increased T3, T4. Okay. And again, how do you treat it is basically you give drugs then you do surgery, and then you obviously maintain your T3T4 level in all of these. You do not want to, very important in a post-op is that you maintain your T3, T4 levels, because you could lead to an myxedema, coma, or a myxedemic attack where there's like decreased T3, T4. And that is actually basically what hypothyroidism, post-surgery hypothyroidism basically means. Okay. Oh, one important thing is that when you're doing your surgery in plumber's toxic nodule, you do not want to give your Lugol's potassium iodine, because it, by the Joes based off phenomena, it can actually cause hypothyroidism. Simple, 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 very simple. There are only certain things that have to be taught in a hypo T3 T4. Again, you know that the patient is going to be dull, lethargic, cold intolerance, weight gain, menorrhagia, bradycardia. TSH high, T3 T4 low. Most common cause I2. Second is Hashimoto. Next is Wolff-Chaikoff pituitary stalk effect, which is causing decreased TSH. Sheehan syndrome, again the same thing, same concept, decreased TSH. Dysharmonogenesis, that is a TPO mutation. Okay, and a sick euthyroid syndrome. Sick euthyroid syndrome is quite interesting to me, because the T3 and T4 is actually reduced, but the TSH is normal. And do you want to actually worry a lot on your sick euthyroid syndrome? Not really. And then you have your last is your Refetoff syndrome, and Refetoff syndrome is basically T3 or T4 resistance. More of T4 resistance. That's not right, T3 resistance, because in Refetoff syndrome the treatment is such is to give T3. So writing T3 resistance is actually incorrect. Okay. So Hashimoto. Let's talk about hypothyroidism. Is basic, very simple. Just very important and very interesting is something like a sick euthyroid state. If a patient comes viral fever and it's not pointing towards any viral thyroiditis, so it could basically be sick euthyroid state where the T3 T4 is low and your TSH is pretty much normal. Just give T3 for some time, and eventually the gland will bounce back and it'll function perfectly well. Let's talk about Hashimoto thyroiditis. Hashimoto is basically your lymphocytic thyroiditis, and it's associated with antibodies. Now antibodies are against what? Obviously it's against TPO, it's against thyroglobulin, it's against thyroid receptors, it's against TSH receptors. It can be against literally anything. Diagnostic is TPO as well. A very important antibody than thyroglobulin is quite used as a tumor marker. It can be misjudged as a tumor marker, so obviously you should keep that in mind, because thyroglobulin tumor markers can be elevated in thyroid lymphoma and certain other lymphomas as well. So these antibodies basically destroy the follicle, and as they destroy the follicle, you will have no regeneration of the follicle, and then you will go into a transient hyperthyroidism because of increased release of T3 T4. So you'll have hyperthyroidism, and then eventually you will again go into hypothyroidism because your T3 T4 have been replenished. And then you will have normal TSH levels that will keep increasing, and you will have a diffuse enlargement of the gland. Simple. And on HP you will see certain thing called as Hürthle cells. Now Hürthle cells are not only seen here, Hürthle cells seen in Hürthle cell carcinoma, thyroid lymphoma, follicular thyroid carcinoma of papillary variant. So many cases you see Hürthle cells, but you see a Hürthle cell in most cases. And when it comes to when you're giving a step 1 exam, if you're giving you old FA, straight off go for Hashimoto. How do you do your diagnosis? As I told you, anti-TPO antibody level, you just do that. You do a USG, and you see your pseudonodular appearances. Okay, USG. And then your management is simple. You do a T3 T4 replacement. Next up is your postpartum thyroiditis. This is really interesting because it's 12 months postpartum. Okay, 2 to 12 months postpartum, you can see this. Okay, there is obviously your TPO antibodies that is again present. Okay, 10% risk of Hashimoto again out here of Hashimoto. And simple is that you want to do T3 T4 replacement. Okay, Very common in females. You should obviously keep this as a DD whenever there is a female who is in her pregnancy and then comes to you. Okay, then we have something called as a dequervin or viral. Let's say there's a viral infection, your interleukin 6 increases. Okay, your interleukins increase, your tumor necrosis factor increase. Finally, your lymphocytic infiltrates in 6 weeks. After 6 weeks, okay, 6 weeks is the minimum time. 6 weeks or 4 to 6 weeks, actually, lymphocytic infiltration occurs, and your entire gland is destroyed. Now, gland is not actually destroyed, your follicles are destroyed. Okay, so let me write follicular destruction. Okay, so basically your ESR is pretty much elevated. Okay, and is this going to be painful? Yes, this is going to be painful. Will you have fever? Yes, you will have fever. Will you have malaise? Yes, you will have malaise. Malaise is something which we do not really want to talk about, because even Hashimoto can come with malaise, but fever and painful is very important. Okay. Management, again, you want to give T3, T4. Obviously, same state of management every year. Okay, and then finally we have a radial thyroiditis. Radial thyroiditis is woody. It's very, very important. Why? Because there's fibrosis of the gland. What is there? Fibrosis of the gland. There's fibrosis of the gland, and because there's fibrosis of the gland, there's going to become woody. Is painless. Very important. Very, very, very important. And as I told you, it is associated with Dupuytren contracture. See, as I said, I kept my promise. I told you Dupuytren contracture is going to come, and it did come. Because I almost said Dupuytren contracture in Graves' disease, but actually it's associated by Addison, pernicious, and myasthenia gravis. It's also associated with Peyronie's. Okay. Treatment, you want to do steroids and tamoxifen. This can come as a true and false. Tamoxifen is actually a breast. You use it in breast as well. So obviously it can come as a true and false. Okay. Finally, we come to the thyroid cancers. Very, very important. Very, 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 very high yield. Very, very, very high yield. And I think we'll take thyroid cancer in the next module. So far, thank you.